Hi, I'm Andy. I'm one of the acute medicine consultants, and I have Sarah with me, one of our advanced care practitioners. And we're going to talk about our medical same-day emergency care today. And for those of you who don't know, the kind of ethos for our medical SDEC is essentially focusing on admission avoidance and trying to provide high-quality inpatient care, but in an outpatient setting, so letting patients have access to all the tests and treatments that we might be able to offer in hospital, but at the end of the day, they get to sleep in their own bed, which we feel is better for everyone all round. And I first had experience of what was ambulatory care back when I was a trainee in 2015 in this trust, and before then I hadn't actually had any experience of ambulatory care or SDEC as we call it now. And if I remember correctly, that was essentially us seeing things like DVTs and cellulitis. Was that when you joined, Sarah, roughly?
Yeah, so I joined in 2016 and it was very different back then. We were based in Gary, Ward 1, so at the back of the hospital. There were more staff than patients in those days, so we really struggled and fought over what we could do for people. And we just thought at the time, how is this ever going to be a viable service? When there's more staff around than patients coming through. So, yeah, very, very different. But it soon picked up.
Yeah. And I think I remember being called very occasionally just if someone became unwell or, a second opinion was needed. But it felt, at that stage at least, I was quite removed from the process on the day-to-day and not really involved. And I think it was predominantly led by the kind of the senior nursing team and the ACPs at that stage, wasn't it?
That's right, yeah. I remember we had one registrar that was a locum registrar that would work with us all of the time, but we didn't really have a consultant presence in those days. Mainly ACP, registrar-led. Very, very different now. The kind of patients that we were seeing back then, we were very pathway driven because of the location that we were in, because of the sort of newness of the service, and there not being a lot of confidence in what we were trying to do. Everything was, just sort of trying to be discovered. We were very pathway driven, so we were very sort of closed about the kind of patients that we took. So lots of DVTs, lots of patients with cellulitis. What else did we see back then? Patients with query pulmonary embolisms. That was one of our sort of founding conditions as well. But we wouldn't really take anybody that was in any way sick. They had to be very, very much walking well.
Yeah. And I think I remember as a trainee that one of the things we had to do was try and get ambulatory care numbers in our logbook. And back then, again, it was quite difficult to get access to the numbers we needed to get our training. But I think things quite rapidly exploded over the next few years because I went away and then I came back a few years later and then it had moved again. Yeah. And I think at that point we were then on AMU in some side rooms.
Yes,
do you remember
we've
that
moved
one?
a number of times. Yeah. I think I tried to count the other day how many moves we've actually had, and I think it's about 6 or 7. Wow. So we had a couple of locations on AMU. We started off in a very small side room with a board in the corridor, and then we would call people in from a waiting area into that one room. So we were very, very small amount of space on AMU. That quite quickly was changed. People realised that actually just couldn't get the numbers through with the staffing in that location. So we then moved to the back of AMU where frailty services then took over a little while later. So that was a real... a real treat. We had a whole bay and a couple of offices that we could occupy. So we could really start to expand and, see more patients. Then we moved round to EMEA. Yeah. Our location in EMEA, which was where we were when COVID hit. And we were being bedded quite regularly at that point. So we really struggled to sort of operate as a service. I know that NHS England now really sort of are really strict about telling trusts not to bed their SDECs because of the organisational impact it has. So that seems like it was a long time ago.
Yeah, and I remember that being one of my real bugbears as a new consultant here was our SDEC being bedded and that sense of frustration that was a relatively short-sighted decision, which meant that when we weren't able to clear through the numbers we might have been able to otherwise.
They've quantified it now, and they say that it takes organisations 3 days to recover from an overnight bedded SDEC.
Wow.
So that's quite a big impact, isn't it, on flow through the hospital?
Absolutely. And I think then us moving to the current location now has been great, because it means that, one, it can't be bedded, but I think we have had that kind of buy-in as an organisation that actually protecting our SDECs is a good thing to do, and the value of the service we bring is now sort of is seen and celebrated.
That is when we really spread our wings, wasn't it? Moving into that location in the old dermatology, where we had all of those clinician rooms in a real dedicated space that was, specifically for what we needed. It was, our service just grew exponentially from there, didn't it? It was amazing.
Yeah. And I think, one of the things I'm really proud of taking that forward is just the opportunities for lots of different staff groups to come through. It forms part of our on-call rotas. So we have doctors from the entire medical division coming down and rotating, and they get opportunity to see things they wouldn't have otherwise seen, or get a feel for how same-day emergency care works, and that idea of admission avoidance, and then potentially taking that forward into their next roles, and just thinking about, could we do something slightly differently on the wards. I think we've really embraced the kind of MDT working with, we've got advanced practice, we have our physician associates, various grades of doctors, our various seniority of nurses, and we all, I like to think, we do really work well together, don't we?
Yes, yeah, we do. We do.
And I think your role as ACPs has sort of been varied throughout, hasn't it?
Yes.
What's your views been on all of that?
Yeah, so I guess to start with, sort of in the early days, because it takes so long to train an advanced practitioner. So, it's slightly better these days as a 3-year apprenticeship that gets people from start to finish quite nicely and neatly. But 3 years is still quite a long time to be able to have an advanced practitioner on the floor able to see patients. But back in our day, we were just doing that from the offset with support of our medical colleagues. The numbers were much smaller then, so that was much easier to do. But we did, I think it was, just trying to think which year it was, that we ran an ACP-led service in Cheltenham for a while to cover a shortfall in the medical numbers. So, so that was a really, really great experience for us as a team, and it was really nice to be recognised by our colleagues that we were able to provide that service. That was great.
And one of the things that I'm really excited about that we're doing now is the rapid assessment part that the ACPs are doing now.
Yeah.
Do you want to tell us a little bit about how that's going?
Yeah, so as part of my final piece of my master's degree, my dissertation project is rapid assessment. So it's advanced practitioner-led rapid assessment to improve flow in SDEC. So instead of our usual sort of standard nurse approach where patients are brought into the treatment area, seen by our nurses who will do a kind of standard set of observations or bloods, we are now basing ourselves in that treatment area with the nurses so that we can front load those investigations that the patient might need, trying to increase the efficiencies and ensure that most of the tests the patient needs are already done and completed with the results by the time the clinician sees the patient, which it's just been hugely successful. I think we've all seen how, the statistics are there that we've shaved off at least an hour, of patients' length of stay, which has given us quite a lot of clinical time back during the day. But we've seen the patient satisfaction scores increase. As you know, we've sent you lots of anecdotal evidence about, picking up really sick patients on arrival to SDEC. We've had a number of emergency calls to our waiting area in the past, and as far as I'm aware, we haven't had any since we started the rapid assessment project to the waiting area.
Yeah.
To the main treatment area that we've identified, yes, but not to those patients that were sitting out in the waiting area with nobody looking after them. So I think patient safety's definitely improved as a result of it.
I think that's a really important thing to highlight. So, off the top of my head, we've identified severe sepsis with meningitis, with a patient being rapidly assessed, treated, transferred to an appropriate area, and then ending up on a neuro ITU. And actually, from the point of how we managed to look after that patient in SDEC was fantastic. They went through the CT scanner. They had their lumbar puncture as soon as they got onto AMU. So everything worked in a really streamlined way.
Yeah.
Off that initial rapid assessment identification of someone who was sick. We've had an ST elevation MI not that long ago, who then ended up going to the cath lab.
Yeah.
We've had a thrombolizable PE, a thrombolizable stroke the other day.
Within 20 minutes of the end of that window, yes.
Yeah. So again, that just getting to assess and have that safety net then allows us to really feel confident in that admission avoidance, and that you know, inevitably we'll have sick patients coming to our SDEC, but knowing that we can respond to them in that sort of way is really reassuring.
Yeah, it is having the confidence to have those sicker patients, isn't it? Which is definitely what we need to be doing in order to avoid admissions, is having those sicker patients earlier in their journey so that we can then make them better and inevitably see these patients go home.
Yeah. So where do you see the future going for us then?
Yes, I think we've got lots of ideas about the future. I don't know what your feelings are, but with the rapid assessment being so successful, we would really like as a team to be able to branch out into the wider acute medicine service and maybe medical assessment zone. We thought that those skills would be probably quite useful for the patients that come into the medical assessment zone to, again, front load those investigations and hopefully make their admission shorter, or you know, maybe get those patients home on the same day even.
I like that idea as well. As you know, we're a little bit separate, SDEC and acute medicine, and blending that a little bit and having the ability to move between the two areas a bit more seamlessly would be helpful. It's always finding the balance between having a space that could be bedded versus not. But it's an exciting time, and I know we've had multiple external agencies have a look and see, and you know, we're sort of on a maturity scale of 0 to 8. We've been graded as a 5+, which is you know, the higher end of where the rest of the region has been graded, and it'd be really good to see what we can do to just push a little bit further.
Absolutely.
Exciting times ahead.
Absolutely. And I'm super excited of I'm super proud of the advanced practice team, because they use rapid assessment now as a way of troubleshooting flow issues. So in Cheltenham, we weren't doing it before this week. They've been using it just in an ad hoc basis to deal with issues with flow. So, it's all good.
Onwards and upwards.
Yes.